resume recording. So welcome everyone to this to our occasional unit lunchtime seminars. So my name is Nai Rui Chng. I'm a research associate at the unit, and today I'm very pleased to welcome Christian to give a talk today on his research. Christian is doing his PhD at the Nelson Mandela University in Tanzania, and today he will be talking about some of the work that he's doing in Tanzania, including a piece of process evaluation work on mass dog vaccination. I think what is really nice about having someone like Christian here is much as we advocate the use of the various MRC guidances, often the only feedback that we get are examples from high income countries. So today I think we're very fortunate to have someone like Christian who can give us some perspective of using the guidance in a lower middle income country setting, as well as in the area of One Health, which has always been important, but following COVID, I think its importance is even more heightened. So Christian, happy to hand it over to you, and you can begin. Ready?
All right, so thank you, Nai, for the introduction. Hi, everyone. So the topic is development, feasibility, and potential effectiveness of community-based continuous mass dog vaccination delivery strategies, lessons for optimization and replication. Sorry, I think my slide, okay, it's moving now. So rabies is a zoonotic viral infection and of mammals, and is usually the disease is harbored in the saliva of infected dogs and could be transmitted to humans through a dog bite or the saliva getting in contact with broken skin, or sometimes dripping into any mucous membranes like the eye or the nostrils. And upon exposure, one has to quickly, within 24 hours, get post-exposure prophylactic vaccination before the disease progress to, to begin to manifest symptoms. Because once the infection, progresses to a disease state, death is almost inevitable. And so, let me limit this slide, okay. So globally, about 60,000, approximately 60,000 deaths occur out of rabies infection. And as you can see from this map, the B figure, about 99% of the rabies burden is in Asia and Africa. And in Tanzania, where we conducted this research, it is estimated that 1,500 deaths occur annually out of rabies infection. However, rabies, there's a proof of concept for elimination of rabies, and that is based on the transmission dynamics of the disease. First of all, is the fact that the domestic dogs have been known as the primary reservoir of the infection, and they are responsible for 99% of infections to humans. Again, these dogs in endemic areas or regions, though we know that in these regions, there are quite huge number of free-ranging dogs, but studies have shown that majority of these dogs are accessible for parenteral vaccination. Then rabies as an infectious disease also relatively has a low spread rate. That means that its basic reproductive number, which is the number of new infections that an infected dog can infect before it dies out of the infection, has been found to be consistently below 2. And so that means that herd immunity can quickly be easily be achieved and sustained to interrupt transmission. But where vaccination activities are organized once in a year, then the vaccination coverage from that one campaign should always reach at least 70% of the dog population in order to ensure that in between the campaigns, the vaccination coverage does not, yes, vaccination coverage and therefore herd immunity does not wane below a critical threshold of 40%, below which the herd immunity is lost and transmission can occur. And this is because of the birth of new dogs, the death of vaccinated dogs, and also immigration of unvaccinated dogs or emigration of vaccinated dogs. So the problem but achieving 70% of dog population has been found to be challenging. And that is because if you look at the current approaches for delivering mass dog vaccination campaigns, which are temporal static point campaigns where dogs are brought to a particular a central point for vaccination, or the capture, release, capture, vaccinate, release approach, which is usually targeted at free roaming dogs, or you can have an approach where vaccinating teams go house to house to conduct vaccination campaigns. But the challenge with these campaigns are that they are usually designed from central government points or from district, administrative offices, and the vaccinating teams have to travel to remote villages to conduct vaccination campaigns once in a year. So they are usually faced with limitations such as bad roads. So it's possible that a vaccinating team might not be able to get to a designated village because the bridge has been washed off the road, or yes, and the kind of limitations. And so because usually the vaccinating teams have to travel over long distances, it adds to costs. There are huge costs associated with this kind of vaccination approaches, with cost per dog vaccinated reaching as high as $7.636 per dog vaccinated. And so that results in inconsistent delivery of vaccination campaigns. And so even though it's been proven that we can eliminate dog rabies via mass vaccination campaigns, we are not able to do so. But there are certain current developments which could help to overcome these barriers. First of them is the discovery that the Novivac rabies vaccine, which is the most commonly used rabies vaccine, is thermotolerant, and it maintains its immunogenicity when stored under 25 degrees for up to 6 months. And just like in the case of rinderpest and smallpox, it opens up the possibility of storing these vaccines in very remote communities and use them to conduct dog vaccinations continuously. Following this discovery, the research team moved ahead to conduct a feasibility study to see how these vaccines can then be stored in remote communities. And that led to the development of a low-tech passive cooling clay pot, which is, when placed out away from sunlight, is able to create an internal temperature of between 18 to 20 degrees Celsius. And so these therefore mean that we can decentralize mass dog vaccination campaigns from district levels right to the village levels. And so the research team then designed a community-based continuous approach to mass dog vaccination and piloted it in order to optimize the design before they test it widely in a full randomized control trial against the current standard approach, which is once annual vaccination campaign. And for the purpose of this presentation, I'll be referring to the current approach, which is the once annual campaign, as a pause strategy. So we embedded a process evaluation into the design in order to contribute insights, formative insights to the optimization of the design. So the rationale for a process evaluation is that if an intervention is rolled out in a particular setting and it failed, it doesn't necessarily mean that the design is bad. That if it does work in a setting, it might also need modification before replication in other settings. So the aim of the process evaluation is to understand the delivery and the impact mechanisms of an intervention. So this is the input outcome chain type of a logic model of the intervention. That is a community-based continuous approach. And the process evaluation follows this process and asking the questions, what are the key intervention ingredients, or how and how do they work to mediate in the outcome of interest? Here, vaccination coverage. Is it because it's continuous or free or community involved or increased sensitization? And then it also asks the question, what are some of the contextual factors that will moderate the potency of these intervention strategies? Looking at infrastructure, policy, and social norms, etc. And then process evaluation also asks the question whether the intervention is delivered as planned, whether the delivery of the components were feasible in the context, and what affected the delivery, and what is working, and for whom is it working. So our overall objective is to generate formative insight for optimization of the continuous, community-based continuous mass dog vaccination strategies prior to the full-scale RCT. Specifically, we describe the development process of the intervention and evaluated feasibility of implementing the component in the context. We explored what is influence the vaccination coverage that is achieved by the versions of the community-based approach. And then we generated lessons that the research team considered in replicating of the intervention. So we followed the UK Medical Research Council's protocol that guides the development of complex intervention, the development and testing of complex intervention prior to full-scale evaluation in an RCT. And this protocol has basically two phases. In phase one, has two main activities. The first activity is to elaborate on how the intervention will work using the evidence that is available. And for this intervention, it was designed on the evidence of the thermotolerance of the vaccine and the feasibility of local storage and the locally made materials, and also the feasibility of being delivered by community-based people. And then the next activity in phase one is to engage stakeholders with a design to get their input and critique of the intervention in order to improve it before it's piloted. And this intervention was piloted, 3 versions of it were piloted against the pause, alongside the pause in the Mara region of Tanzania for feasibility of delivering the component, effectiveness in terms of vaccination coverage achieved, and what lessons could be learned to optimize the design. So we went through the process of engaging the stakeholders with the design and went to the field to test the component. So to describe the development process, we use non-participant observation of the development process, development workshops and meeting reports. We made about 88 hours of observation and 5 meeting reports. And then to study the feasibility of the delivery, we use, again, non-participant observations and audit of the implementation processes. And we're looking at fidelity to the protocol, reasons for variations, and how much work was required for each of the 3 versions of the intervention. And so we conducted about 157 hours of observation, and then conducted implementation audit with the 47 implementers that are involved in the delivery at month 1 and month 6 of rollout. And then to assess potential effectiveness of the intervention, we made reference to the outcome data on the vaccination coverage that is achieved by each of the strategy designs. And we generated the lessons that were used to optimize the design through feedback and appraisal meetings of the research team. So after each stakeholder workshop, the research team comes back to discuss and revise the strategy based on the feedback that they get. And we had 24 of such meetings. And so the qualitative data was analyzed inductively in vivo 12+, and we use Excel spreadsheet just to summarize the quantitative aspects of the data. So key outputs of the development process. The key observation is that the development process was iterative. We had 5 key stakeholder engagement workshops where we have the director of Veterinary Service of Tanzania, the president of the Veterinary Association of Tanzania, the chairman of the Veterinary Council of Tanzania, as well as people from WHO and One Health, and international experts from Washington State University, University of Glasgow, participating in such meetings, and also other local government and health officials also participating. But key interesting is the fact that there were no representation of communities or community leaders in the process. Now, the first output of the development process is 3 delivery strategies of the community-based approach. The stakeholders envision that the approach can be tested, or 3 versions can be tested. It can be delivered in 3 different ways to see which one works best. So a strategy is a combination of the level of the village at which the intervention was delivered, plus one of these approaches. First of them is the temporal static point, where vaccination is organized at a central location. And then you have house to house, where the vaccinators move from house to house to vaccinate dogs, or an on-demand arrangement, where throughout the year, the dog owners can call the vaccinators anytime they have a new dog or new puppies that needed to be vaccinated. So strategy 1, in strategy 1, the vaccination will be conducted at the village level, and you can have a central point clinic plus house to house or on demand. And the rationale is that the village level, conducting vaccination campaigns at the village level makes the workload more manageable for the vaccinators, since these vaccinators are also people who are delivering other animal health services. And in strategy 2, the vaccination campaigns will be delivered at the sub-village level, which means that villages will be divided further into sub-villages. And in our study area, one village could be divided, or the average number of sub-villages range from 2 to 13. And so it means that implementers here will have to do more number of days in terms of vaccination. And the rationale is that what will be the impact of bringing the vaccination campaigns closer to more people on vaccination coverage or participation in the activity. In strategy 3, the implementers will use their discretion to choose whether to do vaccination at the sub-village level or at the village level, and how to use any of these approaches. And the notion is to have a true community input because the vaccinators are going to decide this in consultation with their communities to see which approach they should use. So the second output is an implementation manual. And the implementation manual has described the, to guide the delivery, and it describes the 45 components of the intervention. And so in this table, I fold them into 8 key ingredients and also provided rationale for each. First is that local delivery of the intervention will be led by the district veterinarians. And since they are in the driving seat of animal health activities around the communities, this could help to foster buy-in. The second is the involvement of community leaders in the delivery process. And that is expected to improve the context sensitivity of the delivery process, the design and the delivery process. For example, if you involve community leaders in planning your timetable, they could alert you about some community-wide cultural events as we observed, and those can be avoided in scheduling vaccination campaigns. There's also the possibility of local integration of the vaccination campaigns into routine other animal health activities that a community schedule, such as dipping of animals, and then also the possibility of resource contribution. You could have, the third one is the use of village-based One Health champions, which are village-based personnel that are supposed to help the delivery of the vaccination campaign at the village level. And they know the terrain, and then they could also provide additional human resource needed for delivery of the campaigns. The fourth is strong engagement and sensitization of the vaccination campaigns, and that is to get dog owners to participate, as low dog owner participation has been widely documented as one of the key one of the key barriers to the performance of vaccination campaigns. And then you have the fifth one is the local storage of vaccine with a passive cooling device. And that is to provide access, the continuous access, and remove travel costs between wards and villages by the implementers to go and get vaccines. Once the vaccines are stored at the village level, you have that continuous access, and that will remove cost. The sixth one is a continuous approach to delivery of mass vaccination, quarterly campaigns plus on demand, and that is to sustain vaccination coverage above the critical threshold all year round. And the seventh is the free vaccination clinics, and honor charge campaigns have been cited. Honor charge vaccination have been cited as a key barrier to participation in mass vaccination campaigns. And then also there was supposed to be a feedback loop between the implementers, among the implementers, the research team, and the community. But yes, and that is to enable local and quick response to how the delivery process of the intervention, and to reconfigure the intervention and use that information to reconfigure the design. So a typical cycle of vaccination will look like this. You have district level authorities. They receive the materials from the research team, and then the One Health, community-based One Health champion will have to estimate dog population of the village, feed this data to the rabies coordinator, who is at the level of the ward, who will now made requests for vaccines and vaccination materials based on 80% of the dog population. And then you have to coordinate the delivery with the district so that the vaccinator will not have to travel at all, and thereby reducing the cost. And then the rabies coordinators and the One Health champions advertise the campaigns, they organize the campaigns, and then the One Health champions will have to go back to the houses and check for dogs that missed the previous vaccination and document them for targeting in subsequent rounds. And then there's supposed to be weekly reporting on these activities, and then targeting of dogs that makes last round of campaigns, And then any unused vaccination campaigns, vaccines, have to be returned to the district, have to be labeled and returned to the district office after 6 months. And then there is a review between the research team, implementers, and the communities to review the process. So you have 4 rounds of vaccination, that is quarterly campaigns, plus on demand at any time. Now, on fidelity and reasons for variation, we found that about 50% of the component, of the 45 component of the intervention were delivered as planned. And so in this table, I present examples of these components and how they were delivered. The component that district veterinary officers have to introduce, the One Health champions, was delivered as planned, but they received the letters. They were actually supposed to use letters to introduce them, and some of the champions received the letters very late or just closed the vaccination campaign, and there was no opportunity for them to introduce themselves with this letter to the community in the community meeting. Supervision by district officials were not delivered as planned. These district officials were expecting transport or field allowance, but it could also be because it was not one of the key indicators that was being measured as part of the review process. The One Health champions were to work with mabalozi. In the context of Tanzania, mabalozi are leaders of 10 units of households, and among other things, to estimate the dog population. This was partly delivered as planned in the sense that not all the champions work with the mabalozi. And among several reasons, one of them is the fact that the mabalozi were requesting for money before they help the champions. And this may have been due to the weak community entry that accompanied the initialization of the process, which would have systematically introduced the intervention to the communities. And one Balozi was reported to have said, you went to the workshop and received big allowances, and you have come to tell us to go and do the work. So they thought that the champions received some allowances, and so if they are going to help them, then they should also receive part of that. And then OHE, the champions having to go to households and find dogs that missed previous vaccination was not delivered. Because if they have to just go into the village unguided by any register of where these dogs live, it might be difficult to really go into each household and find out if their dogs were vaccinated or not. So that was not delivered. It may have been labor intensive, and so it was not delivered as planned. Then also, there was on conduction of quarterly vaccination campaigns. We found that only 3 out of the 9 teams actually had, conducted quarterly activities throughout the year, and their schedules were affected by social events such as funerals, cattle auction markets, national events such as elections and enumeration of households for national planning purposes. Also, we found that the rabies coordinators, who are also the livestock field officers for the ward, are people who are, aside their government assigned duties, they are also busy people who deliver private animal health services to other people. So they are quite busy people. And then also the seasonality of the farming seasons. For example, some farmers will tell you that in the rainy season or in the farming season, it's either I have to be in the farm or my dog have to be in the farm to guard the farm against animals like monkeys coming to eat the crops. And then the implementers were also supposed to muzzle potentially aggressive dogs, but this was not delivered as planned. And the problem is that usually if the owner cannot handle their dogs, then the vaccinator, who is a stranger, is most likely will not be able to do that because the dog will be more aggressive. And so the implementers perceive this as time consuming, but they also express the fact that they find it difficult to do, and the dogs are too fierce to use it on them. It will get loose. We are afraid. We use the white stick. So the white stick is another device made of stick that they were using to restrain the dogs instead of using the muzzles. And that is basically because they were afraid that the muzzle might break and they might get bitten by the dog. And so, reporting on dog vaccines and the temperature records of, dog vaccination and the temperature records of the facility or the device that is being used to store the vaccines were delivered, were done timely as planned. Now, in looking at what influenced the reach of the versions of the design, we considered the amount of work, which is the advertising and campaign days, and then the nature of the designs of the three design strategies. And from this figure, we see that the number of campaign days decreased sharply in all the strategies from month 1 or round 1 towards the end of the year. And so you have up to 80% of the 237 days, campaign days, be used on the first 2 campaigns. And so looking at what could account for this, first of all, the number of days that the strategies will do is kind of fixed by the design of the strategy. But also, because of lack of supervision, the implementers may have relaxed as a result, during subsequent campaigns. Again, there may have been implementation fatigue, considering the fact that the rabies coordinators have other livestock responsibilities. They have to dip a number of animals in addition to other animal extension services that they have to deliver to a number of communities. And also there are also people who are involved in their business, private animal health delivery services. So they may have this arrangement of having to deliver 4 rounds of vaccination campaign for rabies alone may have been a little bit overwhelming for them. And so from the process evaluation point of view, we could ask the question whether this arrangement is working for the rabies coordinators, and also if they really need to conduct 4 rounds of vaccination campaigns in order to attain the vaccination coverage that is required to interrupt transmission of rabies. So the amount of work that they input varied across the strategies, but it does not really tell us anything about the vaccination coverages that they achieved. So if you look at the number of advertising that they did per village and the hours of advertising per village, as well as the number of campaign days for per village, it's always higher in strategy 3, but it does not really follow the same trend in the vaccination outcomes. But so that then raises a question or bring the interest to look at what other factors from the context point of view that might be important in influencing the vaccination coverages achieved by the, and an example would be how communities are responding to the vaccination campaigns. But it is notable that all the 3 versions of the community-based approach achieved vaccination coverages way above the 40% critical threshold. But the PAUSE, which is the once annual campaign, which is expected to achieve 70% or greater, is not able to as supported by the literature on vaccination campaigns, it's way below the 40% mark. So considering how the intervention could be optimized before replication, one of the themes is coverage estimation, or one of the things we look at is coverage estimation. And in the context of the pilot, dogs that were vaccinated were microchipped, so that later the microchips can be scanned to know which dogs were vaccinated and which ones were not. But preparing the microchip before it is inoculated or it is injected into the dog, and then injecting it into the dog, because the microchip needle is a bit bigger than the needle that is used to deliver the vaccine. So it usually causes a lot of irritation to the dogs and makes them to become aggressive. And so the preparation process and injecting it into the dog tend to be a lot more of time consuming for the implementers. And so in the context of the RCT, the research team is considering a facial recognition application of recognizing dogs that have been vaccinated as against the dogs that have not been vaccinated. So all these ways of estimating coverage are things that are still under studies, and their routinization will be mainly dependent upon the cost and pragmatic considerations and how they compare with use of vaccination cards or transect surveys where dogs are painted or given colors, and then transects are conducted to see in the community to see which ones have them, or honor recall, which can be conducted in the school-based or household or community-wise. So to be a comparison, the cost effectiveness of these two as against these other current approaches. In line with having to estimate dog population, and based on the experience of the implementers, we also think that building a village dog registry, usually you can have the paperwork, but also if it can be done we can have an electronic database which can be scaled up to the national level, might also be helpful. One, in planning for vaccination logistics, and then it also means that after the vaccination campaign, you don't need to spend extra money going into the village or conducting, moving around to estimate dogs that have been vaccinated. You can just look at your database, because this can be ticked whilst dogs are being vaccinated. And then, by looking at your register after the vaccination campaign, you can tell which dogs have been vaccinated and which ones have not, and where do they live. So you can quickly target these dogs after vaccination campaign. But this, again, is at the level of recommendation, and we need further interrogation to see how it could be implemented. Now, in ensuring that vaccination activities proceeded smoothly, we also identified that usually when the dog owners are given collars to tie on dogs that have been vaccinated, and usually because the dogs are usually agitated at the end of the exercise, they end up biting dog owners. And we think that this could have a negative impression, could feed into a negative impression of dog owners in having to bring their dogs for vaccination. So we could have these less painful activities like tying of collars earlier on in the process, for example, before they are inoculated, so that once they are inoculated and become agitated, nobody really have to manipulate them anymore, and could affect dog bites. Again, in the context of the full RCT, the community-based One Health champions are required to be village chairpersons in order to address the power dynamics at a community level, because in the pilot phase, they were just these champions were just ordinary people, and sometimes getting cooperation from the village leaders and other community members is challenging. But if the village chairpersons are people who are elected, representatives who are elected by the whole village, and they weigh a lot of influence, and that will help in mobilizing for vaccination campaigns. So we conclude that it was feasible to deliver most of the component of the intervention with some modification, and all the versions of the community-based continuous approach sustain vaccination coverage above the minimum threshold. However, they might need improved supervision, which might help to sustain the campaign actions, and also bringing communities on board could also help to improve and sustain the outcomes of the vaccination or the outcomes of the vaccination activities. So I have done this work with support from these organizations, and I thank you for the opportunity and your kind attention.
Thank you, Christian. That was great. Are there any questions or comments from other attendees of this talk? Feel free to use the Q&A option, or if you like, you can also use the chat function to paste your questions and comments. So while we wait for the other attendees to string their questions together, I have a question to ask you, Christian. That was a very comprehensive description of what you've done, and I really like the lessons that you reflected on. How did you or your colleagues on the project found using the guidance to guide the development of your project? Was it something that was straightforward to use, or did you find that it was more challenging than you expected?
I believe that yes, it is quite straightforward and interesting to use in the sense that it provides the context, the theoretical framework within which to progress with the development of the intervention. And so yes, we have not really encountered so much problem. I think the guide is quite clear and relatively easy to follow, and the context of it provides for developing the intervention is quite clear.
So what will your advice be to other projects or programs who are hoping to use the guidance? Do you have any advice for them on how they can use it or adapt it?
Yes, adapting, I will be open to it because the context will be different. And so adapting it might be something that will be necessary depending on the context realities. But recommending it, I will strongly recommend, especially doing process evaluations of the several interventions that are ongoing, especially in the South, and they should it will be useful if sorry if they are done within this kind of theoretical framework or guidance, so that it becomes easier to exchange the knowledge widely. The knowledge can be understood in other context. Yeah.
Thank you, Christian. So we have two questions from the attendees, and they are both on the same topic. which is great. So both Sarah and Katie would like to ask you, Christian, about the dog registration. If you could share some ideas on how it can be made more effective or efficient or improved.
Yeah, so this is something that we are proposing. Sorry, we are proposing at this phase, and so it will take one engaging more with local authorities and to see how it can be done, because one, it will require a lot of resource input, and so if it can be supported resource-wise from the village level, it will be very important. And I think that is the key element that is required, that is support for it at the village level to get it delivered. And the important question, or a more useful question that we could ask is, who are the people in charge of the resources at the village levels? And if at all they are interested in rabies, and they might be willing to commit some of these resources to developing this village dog registry. So, sorry, once we could move it from a paper phase to an electronic database, then there is scope that it could be used in many ways. As I explained, it could be used to estimate dog population planning purposes. It can also be used to estimate a dog's coverage, vaccination coverage, and that may eliminate the work that has to be done, or the cost and work that comes with the current approaches like transect surveys, where people have to actually go back to the communities and conduct these surveys, and with its attendant costs. Yes, so back to the issue of community resources to rape, there are opportunities of, for example, motivating people to actually get their dogs registered. We could, motivate people. We may not have to focus so much on punitive measures, but look at things that could motivate people, like other benefits, maybe providing the dog. If, for example, we could say that if you have registered your dog, you have your dog registered, your dog could be given a dewormer, or essentially we can couple this activity with any other activity that is going on at the level of the village, any intervention that is going on at the level of the village, in order to motivate people to get their dogs registered. So the key potential barrier here is the willingness of people to actually commit resource. But once we can get around this barrier, it could become a useful tool in assessing coverage and also planning massive vaccination campaigns. And then in the context of providing the continuous vaccination, if we have a register that links dogs to the households where they live, then immediately by looking at this register, you could tell where the dogs that missed the previous vaccination campaign live, and you can quickly target them for vaccination. And yes.
Yeah. So thank you for answering. I think you're answering also Sarah's follow-up question, weren't you, Christian? I would like to follow up on your point about the importance of resources from the village to support this. And my question relates to something that runs through your entire presentation, and you've been quite explicit about the fact that in the design of the project, for example, you reflected that local communities were not involved, didn't you? And this seems to be a theme running through the project, because subsequently you also discovered in your findings that there was quite a degree of tension between the One Health champions and the Balozi, right? I wonder if you can reflect more on this and maybe share how far the seemingly lack of or insufficient participation by local communities in the entire process may have had some impact on the extent to which you were successful in your strategies.
Yeah, so that is the outcome of what actually happened. So there was no specific, you have people from the communities, like livestock field officers, district veterinary officers and the like, who participated in some of these meetings, but specifically there was no community leaders or decision makers represented on these in these workshops. And that is one, because the reasons for these workshops are to address issues relating, bordering on policies and permissions that have to be granted from higher levels of administration. So when the research team introduced the design to stakeholders in the Mara region, there arose questions about the safety of storing the vaccine in the low-tech cooling devices, and also the use of community-based personnel to deliver the intervention. So then there was the need to climb up and engage people in the higher hierarchies. So I believe that is what, then the focus was then on getting buy-in from these people, and that may have caused the fact that communities were left out of the process. But we know that if there were systematic involvement of communities, then it could foster buy-in from these communities. And yeah, so one of the concerns that the Mabalozis have, or the perception, is that this is a project that is coming with money. And so anybody, if they are going to get involved in it, then they should get some of those money. But if they were involved to discuss these, the aims and objectives of the projects and the possibility of community participation, then probably they may have come to it with a different perspective. And actually, there is scope for community participation or benefit to their involvement. The first of the fact that the context is so variable. If you move from one district to another, there's something likely to change about the community setting. So if you sit at the regional level, for example, and you plan an intervention for across a number of districts, you might be missing out on certain contextual factors that will affect the implementation in reality. For example, in Tarime ward, for example, implementation have to come to a halt for a whole month, because they are doing this puberty right celebration for that is when young men come of age around the age of 14 and 15, and they are circumcised together, and there's a huge cultural celebrations, and nobody was really minding the vaccinators, so they have to hold the vaccination activities for a whole month. And so the community leaders know these things, and when that discussion is had, they'll be able to actually help in planning these activities so that they don't get interrupted too often.
Thank you, Christian. I think we have time for one final question. And the question is, did COVID affect the design or the delivery of the program?
Come again, please.
How did the pandemic affect the design or the delivery of the program, or did it?
Basically, it affected the implementation process. So during the heat of the peak of the pandemic, activities were suspended. Yes, but we have not looked at systematically look at uptake of the intervention by way of the onset of the pandemic. So I see one question here from Katie. She's asking about if the register can be effectively and efficiently updated given dog population turnover. Yeah, so I think that once we have this discussion is halved and people are aware and we have the mechanisms in place and they are resourced, whatever they need to do this are resourced. It can also be part of the protocol that we are updating the register every 6 months or every 3 months. And then the system, how it's supposed to be done, will have to all take care of that. Yeah, so I think it's possible once it is incorporated into the design and whatever is needed in terms of protocol description and resources are provided, it's possible that it can be done. For example, already in the context of Tanzania, the Mabalozis and even the sub-village heads are supposed to know how many animals are there in their areas anyway. So this is also an opportunity where it can easily be coupled together, and then it becomes a channel through which it can be, updated regularly.
Thank you, Christian, for your reply. So I've put Christian's email address in the chat. So if you have any other questions or comments about his study, do feel free to get in touch with him. It just remains for me to thank Christian once again for sharing your very interesting research with us. Thank you, Jonathan from the unit, for setting us up. And thank you, everyone else for making the time to come to this talk. And we hope to see you again at another unit talk sometime soon. Goodbye.
Thank you.